So again, thank you for joining the fifth virtual resident education lecture series. Today's topic is sleep medicine. All participants are muted, and if you are having any technical difficulties, we recommend disconnecting from the webinar and reconnecting. You can connect using computer audio or by the dial-in option, and you do not need to use both. If you continue to have technical difficulties, send a message through the chat feature and we will try to assist you. For questions, we ask that you use the Q&A feature on Zoom, and we will answer them throughout the talk and at the end. We have Dr. Shilpa Chitnis joining us as Q&A moderator today. Dr. Chitnis is a professor of neurology at UT Southwestern Medical Center. She is a clinician educator with focus on movement disorders. I'm also pleased to introduce our speaker for today, Dr. Rachel Salas. Dr. Salas is a professor in the Department of Neurology at Johns Hopkins Medicine with a joint appointment in the School of Nursing. She is board certified in sleep medicine and neurology, and Dr. Salas will talk about the importance of sleep. So tune in to learn more about the culprits of disturbed sleep, signs and symptoms of common sleep disorders, and new strategies you can employ now to improve sleep behaviors and practices. Dr. Salas, I will turn it over to you.
Thank you very much. It's a pleasure to be here. I'll start with a disclaimer that hopefully you'll get some information out of this webinar, not only for your patients, but also for yourself. And if you're an experiential learner, then you can take a nap, and that, in my opinion, would be helpful too, because many of us out there are sleep deprived. So let's just go through some background real quickly. Humans, on average, should be getting somewhere to 7 to 9 hours of sleep. Now, everyone, especially physicians, think they're special and think they only need 5 to 6 hours of sleep. It's not true. You are special, but not when it comes to sleep. Most people need, again, 7 to 9 hours. According to the National Sleep Foundation poll, they do a poll every year and they survey Americans throughout the country and say, how much sleep do you get? Now, of course, it's subjective, but most people say, you know what, I probably do get about seven hours of sleep per night, 7 hours and 36 minutes. But only 35% of those individuals report having good quality sleep, right? So there's definitely room for improvement. Some of you may be surprised to know that there are 80 different types of sleep disorders. And that's, these are defined sleep disorders in our International Classification of Sleep Disorder edition. $80 billion a year are thought to be attributed to the consequences of poor sleep. Now, whether that's, missed work, poor productivity at work, car accidents, or other major accidents, that all of that factors in. 80 million Americans annually suffer from the consequences of poor sleep. Now, whether that's because they have an undiagnosed, untreated sleep disorder or just not getting enough sleep, that's a mixed bag there. 60 million Americans on average meet the diagnostic for a sleep disorder. They meet the diagnostic criteria for a sleep disorder, but only about 40 million are diagnosed and treated. So we got 20 million Americans out there undiagnosed, untreated, and guess what? It affects us all. According to the CDC, about 36% of Americans report feeling drowsy while driving in the last month. So, that again can affect us all. And, as the population gets older, it turns out that 50% of individuals over the age of 65, 50% of them meet the diagnostic criteria for a sleep disorder. And many of them, again, are not diagnosed and not treated. So we all know that, physicians or any clinicians, if you practice good behaviors, like you don't smoke, you eat right, you practice wellness, you're more likely to engage in counseling for your patients and ask them about those practices. Well, the same holds true for sleep. So that's my job here today, is to get you thinking about your own sleep practices, and hopefully you can improve things and then, talk to your patients about sleep disorders. Now, the truth is sleep, especially, when I was in training, we didn't get that much sleep medicine education in our medical school curriculum, and then probably even less in residency. So a group of us, not just sleep educators, but neurology educators, came together and, proposed different ways to implement sleep medicine throughout, the medical student curriculum. So I think that more and more nowadays, people are seeing that sleep is important, and it's one of those disciplines that transcends all the other disciplines, right? No matter what specialty people go into in terms of, their practice, they're going to have patients with sleep issues, either acute or chronic. So I'm here to remind you that sleep is a basic human need, right? It's not something that, we can take or leave. We need to do it. Most of us don't do it well. I'm not going to get into the physiology here about sleep. Most of you are very aware that there's a circadian rhythm process that's important with our sleep. But there's another process S, which is the homeostatic drive. And the idea here is that if you had good, adequate sleep the night before, if I said, go ahead and take a nap right now, you shouldn't need to go to sleep because you had good quality sleep the night before. And so as you go through the course of the day, right, around 11 p.m. for most people, your sleep propensity is going to be at the highest. And that really should be when your circadian rhythm intersects, right, making it a high chance of you falling asleep. But the truth is, most people, Americans, especially healthcare clinicians, are just really falling asleep because they're exhausted, not because they have good sleep practices. And what's the problem with not having good sleep, whether it's because you have an undiagnosed, untreated sleep disorder, or you're just not getting good quality or enough sleep? Well, the problem is that the sleep drive is pretty strong. So when you're hungry or thirsty, your brain can give you signals, right? I mean, you can even get your stomach might growl, you might get hunger pains, but your brain cannot pop a plate of food in front of you or make you drink something, right? But when your brain is sleepy, it'll make you sleep. It doesn't care what you're doing. You could be driving, you could be doing a delicate procedure, and your brain will literally fall asleep for 1 or 2 seconds without you even knowing. And if you're driving, again, doing a procedure, that literally can be the difference between life and death. So it's important to go through this. Now, if you get a chance, this is the Epworth Sleepiness Scale score or scale that we use clinically for a patient. And what it is, it looks at these 8 different scenarios, and you rate the chance of you kind of dozing off in these different scenarios. And if you score above 10, that suggests that you have pathological sleepiness. So something else may be going on there. If you probably go through there, I wouldn't be shocked if many of you are above the score of 10. And so this is a study back before duty hours, but they were looking at different residency programs, and they were looking at the Epworth Sleepiness Scale score, and you can see different specialties here. Neuro's not in here, but you get the idea with the other specialties that are here. All of the house staff that were included in the study were looking like a patient with obstructive sleep apnea, so OSA, or even narcolepsy, right? So it was a problem, and of course, duty hours were implemented back in my day when I was a resident, and the verdict's still out on the pluses and minuses with the duty hours, but it's still a problem, and definitely nowadays when we're even more connected. People are just not getting sleep, and it's having an impact on our healthcare professionals. So we know, and this is all by evidence-based studies, that if you're not getting good sleep, again, either you have an undiagnosed sleep disorder or you're just not getting good quality or enough, that it can have consequences. As much as having issues with your residency program, burnouts, higher, reduced quality of life, mood disorders. We've all experienced not getting enough sleep and feeling grouchy that next morning. But if it's chronic, it can cause problems and problems interacting with other healthcare team members, even your patients. And this is from one of the studies that I just talked about, just showing the odds ratios for different scenarios where residents averaging less than the 6 hours of sleep per night already were having increased risk of these things, increased alcohol use, serious conflicts with others, accidents at work, safety issues with patients, and even driving accidents. So there are consequences here, even if you're a healthy person, right? So I could just sit here and say, get some sleep, we're done, right? And just move on. It's that easy. Well, it's not. And so I'm hoping that when we're done here, you can get some strategies to hopefully not only improve your sleep, but also be in tune with issues pertaining to your patients. So we all have lots of things, on that we're engaged in, just trying to live life, right? And it turns out that sleep becomes less of a priority. Most of us would rather stay up and watch Netflix and, finish our show, do that binge show watching, or do other things. COVID has made things a little bit less open for us to go socialize and build relationships. But a lot of people are watching more and more TV and on their social media sites and things like that. And it's causing sacrifice of sleep. So I'm not here to tell you, again, to sleep. I'm hoping that I can give you strategies that if you can improve some of your practices and be in tune with some risk factors that you may have for a sleep disorder, that I can improve your sleep. So again, sleep is a basic human need. We need about 7 to 9 hours. If you're falling asleep within less than 5 minutes, like if you hit the pillow and you're already like out, that's a red flag that you're sleep deprived. Again, maybe it's because you're not getting enough sleep. Maybe you are getting enough sleep, but you're still that tired. That's a red flag, right? And turns out that we should cycle through the normal stages of sleep at least 4 or 5 times. And up there is a hypnogram, of a normal average adult showing, the different cycles we'll go through. But the truth is, especially for clinicians, especially for residents, that are on call and whatnot, you're getting frequent arousals, frequent awakenings, maybe even have to go do consults during the evening or the night. And your sleep becomes what we call fragmented. And even if you were to get 8 hours of sleep, it's very fragmented and it's therefore more poor quality, and you suffer like a sleep deprived person. And no, you're not having a hypnagogia or hypnopompic hallucination. That is me in cartoon form. And I'm here to tell you that, studies have shown that when you get less than 6 hours of sleep, and remember, many of you think you're special and only need 5 hours of sleep. But there are studies showing that you're at increased risk for obesity, stroke, diabetes, coronary artery disease. There was a study in young, healthy individuals that are like in their 20s, right? And they said, okay, we're going to sleep deprive you just one night. And I'm not talking 2 or 3 hours of sleep. They gave them 6 hours of sleep, right? And even after one night of 6 hours of sleep, so again, sleep deprivation, they already had changes in their metabolism. These are the top sleep disorders. People are pretty surprised to see the first one, chronic insufficient sleep, right? How is that a sleep disorder? And that's where we are. Sleep awareness is becoming better. People are seeing that sleep is obviously important and they're making it a priority, but it's still the number one sleep disorder out there. And then insomnia, that's probably the number one sleep disorder that we see in our clinic that patients come in for. Circadian rhythm sleep-wake disorders, which many of you, if you have not already experienced, will be experiencing because that's very prevalent in those that are practicing in medicine, sleep apnea, and restless leg syndrome. And as physicians, we may not all get, diagnosed with coronary artery disease, cancer, stroke, but the chances of you being diagnosed with a sleep disorder are very high, if not one, maybe even more than that. I'm not going to talk about these other sleep disorders, but I think they're important to mention. Bruxism, which is grinding of your teeth, a red flag for sleep apnea. Sleep inertia, you've all experienced it. It's not really a disorder, but it's when you wake up in the morning and you just kind of slow to kind of get going. You're like, I need my coffee. That becomes more prevalent when you're sleep deprived. Then we have the parasomnias, which, typically we see in children, but they do come back out if you're sleep deprived, have a crazy rotating schedule like a resident might have. These parasomnias can come back. And then you have more serious parasomnias like REM behavioral sleep disorder that can be associated with neurodegenerative disorders like Parkinson's disease. Of course, we have our central hypersomnias, the narcolepsy and idiopathic hypersomnia, and then just other things that people kind of do now when they're sleep deprived that they may not realize. I've had patients order stuff at 3 a.m. and not remember because they're doing these like parasomnias while they're sleeping.
And Dr. Salas, we also have a couple questions. So the first one is, my sleep latency is very short, maybe 1 to 2 minutes. Is this concerning?
Yes, I would say the first question you would ask yourself is, am I getting enough sleep? And so you would do a little experiment, like, and I know you're not like, having vacation for like a month or anything like that. But if you get a few nights of sleep and you're still falling asleep within 1 or 2 minutes, that's a red flag. You may have an undiagnosed, untreated sleep disorder. And I don't know about you, but residencies and fellowship are hard enough. To be in there with the undiagnosed, untreated sleep disorder, that's a red flag. Now, if you find out like, okay, I'm falling asleep 1 or 2 minutes, but I'm like on night float or I'm on consults or, it's been crazy this last week, then it's likely that it's because you're sleep deprived or your circadian rhythm schedule's off.
Okay. And we also had a question similar to this. They're saying they're falling asleep as soon as they hit the pillow. They've slept like this most of their life. And I'm awake during the day minus during residency. So similar answer then.
Yeah, it's very common. And that's why I always make that point to mention that if you're falling asleep within 5 minutes, that's a little bit of that's a red flag. And you should really kind of dig in there. What's the problem? Are you not getting enough sleep? And then you should try to get, increase your sleep and see if that improves. If it doesn't, is your timing schedule off? Then, and a lot of times it is. And I don't really have sleep issues. I'll just give you a personal anecdote. But when I was a fellow and I was learning about the circadian rhythm, I learned that, typically a human probably on average will go to bed. Our circadian rhythm set to go to bed at 11 and wake up at 7, right? Of course, there's people that deviate from that, but 11 to 7 is like the gold standard. So I said, okay, well, I'm not going to change anything else. And I definitely have behaviors that I could improve on in terms of my sleep, behaviors. But I just did 11 to 7. And I will tell you, after I was going to do it for 2 weeks. And after 5 days of doing this 11 to 7, I was actually pretty annoyed because I had not slept that good since middle school. And so the timing of your schedule is so important. In fact, it might be even more important in certain individuals. So it's not just about getting enough sleep. It's about being consistent, going to sleep as much as you can at the same bedtime and waking up at the same awakening time, even on the weekends when, many of us want to sleep in. Naps, a 2-hour, 3-hour, 4-hour nap, that's not a nap. That's a sleep period. So those of you that are going home exhausted, crashing out for like 3 hours, waking up, putting orders in or reading, all you're doing is just feeding your sleep disorder. And that's what a circadian rhythm sleep disorder is, which will lead to insomnia. So for those of you that are experiencing that, on this, we know that the effects of poor sleep, again, poor quality, not getting enough, undiagnosed, untreated sleep disorder, leads to all these things. You can hallucinate, reduce performance, forgetful concentration. You're more likely to engage in scapegoat activity, risky behaviors. Maybe you kind of, do something like you're doing a lumbar puncture and you'll take an extra risk. Mood issues, depression, anxiety. You also look older, you're going to gain weight, probably get sick more from like infections like cold and things like that. Decreased pain tolerance. So I don't know about you, but these are not something that I would be shooting for. And a lot of people think they're healthy, especially clinicians. And believe me, I went through this too. You don't really kind of see that you probably might have something going on in the background. And there are things you can do. So I'm going to start here with sleep apnea. Obstructive sleep apnea is the more common one. I'm not going to get into central sleep apnea and mixed sleep apnea. But basically, apnea is when there's a cessation of airflow for at least 10 seconds or more while you're sleeping. And it's due to, the collapsing of the airway, and there's different risk factors for that. So one of the questions I like to ask people is like, do you snore? And most people are like, no, I don't snore. But then my next question is, has someone told you snore? Because a lot of people don't admit it, right? So it's like the sleep witness. So if you snore, it doesn't mean you have apnea. But that's, again, a red flag. So you snore, you're falling asleep within 5 minutes, you're tired, again. And even if you're falling asleep during this presentation, that's a red flag that something's going on with your sleep. I don't care how boring somebody is, you shouldn't be falling asleep during the day. And if you are, that suggests something's going on. Now, all of these things on here are backed by evidence-based medicine, showing that if you have untreated sleep apnea, you're going to have all of these things. GERD, that's a big red flag for obstructive sleep apnea. Gaining weight, even though you're eating right and exercising. How many people can relate to that, right? Difficulty, memory, and concentration. You just can't remember as much as you could. People that have OSA or more will, and you have a family risk of heart disease or diabetes. A lot of times these people, because they're not diagnosed and treated, they run to these things sooner in life, right? They were probably going to get it, probably, right? But they get it sooner. and they have to be on therapy sooner. Arrhythmias, we pick up a lot of patients with atrial fibrillation. In fact, the cardiologists send patients to our center to get worked up before they do ablations and things like that. So, and stroke, right? Stroke, hypertension. I mean, these are all things. Apnea is its own independent risk factor for stroke, but then it actually increases the other risk factors like hypertension, diabetes, and heart disease, again, elevating that risk for stroke. And that could be its own separate talk. So do you have a bed partner? Ask that bed partner about, hey, do you notice I stopped breathing? Am I snoring? Am I grinding my teeth? Again, all red flags for me. Always say, do you wake up in the middle of the night and more than maybe 2 times a night, and you're not really sure why, but you're like, okay, I'm thirsty or I have to go to the restroom? Actually, if you're waking up more than 2 times a night, that could suggest something is going on. A lot of times it's apnea waking you up. You're just not realizing it. And if you're sleepy during the day, even though you got good, adequate sleep the night before. Now, these are all risk factors for apnea. So being a man, I mean, how many people in this webinar so men have bigger necks, more muscle tissue, testosterone plays a role. Postmenopausal women, a lot of times, women are underdiagnosed and untreated for sleep apnea because they're not the typical, overweight, patient that may be coming in. They may be underweight, actually. Small airways. So we do the modified Mallampati score. Have the patient just kind of open up their mouth. Do not stick out their tongue. Do not say, ah. And then we kind of grade that. So if you're somebody who has a small airway, or if you have micro or retroagnosia, even if you're not overweight, that's a big risk factor. I have many patients underweight or at a normal weight that have severe sleep apnea. Now, typically, race and ethnicity does not really play a role for the most part in sleep. However, if someone phenotypically has like an Asian background, we're going to use that term very broadly, right? Because it could be Japanese, Korean, Indian. A lot of people from that background tend to have smaller airways, and that's a big risk factor for apnea. So we always ask about family history as well. Neurological disorders like Parkinson's, multiple sclerosis, epilepsy, stroke. A lot of the neurological disorders increase the risk for sleep disorder, particularly apnea. So there's a question.
This is Shilpa Chitnis. Does snoring need to be loud? Is a question one of the people have asked.
It doesn't. Actually, you could, so women, and I'm being very general, it's not always the case, but women, for example, might not even snore. They might just not breathe. So that's why they're more difficult to pick up. So it doesn't matter on how heavy the snoring is or how light the snoring is, or if there is no snoring. If you have risk factors on here, you're grinding your teeth, waking up in the middle of the night multiple times, tired even though you're getting adequate sleep, have people in your family who have sleep apnea or even snore, and you have these other risk factors, 80% of people who meet the diagnostic criteria for sleep apnea are not diagnosed, 80%. And they're now putting obstructive sleep apnea as a cause of death on death certificates.
So another question is, can we diagnose sleep disorder when there is a recent confounding factor like starting or changing the dose of an SSRI?
For apnea, yes, right? We would still do the workup. That's not going to impact. There are some SSRIs that actually could have a positive benefit for apnea, but not. I don't think clinically it's not to the point where it would alter anything. But in terms of insomnia, it may be a little trickier. But I would, if you're concerned with sleep disorders, which many times patients with depression or anxiety, but several other psychiatric disorders, a lot of times we work really closely with the psychiatrist. So if sleep is on the radar and you're going to be working on medications, I definitely would connect them with a sleep specialist just to optimize care.
And last question is, and I'm not sure whether this was asked before. So in ancient times, it's reported that we should normally sleep in 2 sessions with several hours of alertness in between. Can you comment on whether this is the normal biological sleep architecture? And I think you kind of commented on it a little bit earlier.
Yeah, and that's a good question. It's very fascinating that this idea of 2-part sleep, there is I think Roger, I'm blanking on the last name, but he's in Virginia, had done a lot of research looking at, sleep in human beings. And the idea was that humans naturally had this two-part sleep. And then with the invention of the light bulb and then the Industrial Revolution, it was optimized where you kind of condense that two-part sleep into one, so that you could work and be more productive. And since then, we've kind of maintained that, right? And so there is an idea that insomnia, especially when you wake up in the middle of the night and can't go back to sleep, is the natural tendency of humans to want to go back to that two-part sleep, right? So back in the day, the idea was that you would have this, you would have like hardcore manual labor type jobs, and you'd come home, you would eat a huge dinner, and then you would have what we call the deep sleep. You'd do that for a few hours, wake up probably around midnight or 1, and then do some light stuff like pray, feed the animal, do some light chores, a lot of things that people would do during that time. And then they would go back to sleep for the lighter portion of their sleep. And so it's very fascinating. I think the jury's still a little bit out, but it makes sense to me. And so there are people out there that are really experimenting with how to optimize their sleep with the timing, right? I talked about earlier, 11 to 7 is typical good starting point for most humans. But do I have patients and athletes and people like really into sleep awareness that are tweaking it and going to bed and saying, you know what, when I go to bed at 10:52 p.m. and wake up at 6:45, like that's my optimal time. So people are really getting into, kind of what I'm calling precision medicine and really individualizing not only the timing of their sleep-wake schedule, but even how they sleep, the position. People are really digging into that. Yep. Sleep apnea, just a little plug here. So PSG, polysomnography, that's the gold standard. As a sleep neurologist, typically we see more complex patients at Hopkins. So a lot of times we're bringing our patients into the sleep lab to do an overnight polysomnography. But for bread and butter patients, many of you that will be in private practice or in other specialties, not in sleep, you connect with a sleep center, and you can do home sleep apnea testing. And the devices are pretty good now, and they're able to detect not only obstructive sleep apnea, but central sleep apnea, which is obviously something of importance for our patients with neurological disease. It's more cost efficient. We're able to get people treated sooner. And, it's really kind of where we're going, the more ambulatory form. This is to show kind of what we record in a overnight polysomnography. And this is the in-lab one. Obviously, the home sleep apnea test has decreased amount of, biological features, but we do a single lead EKG. We have video. Sometimes we pick up abnormal parasomnias or even seizure, REM behavioral sleep disorder, and OSA or sleep apnea are the two reasons why you would order a sleep study. You never order and the insurance would never approve you to get a sleep study to make a diagnosis of restless leg syndrome, for example, or insomnia. But we will do an overnight polysomnography as well as a NAP test, the multiple sleep latency test, the next day when we're concerned about narcolepsy or idiopathic hypersomnia. And we have scoring criteria. This criteria is always updated by the American Academy of Sleep Medicine. And we, unlike our colleagues in epilepsy who tend to look at the EEG like in maybe 10 to 15 second windows, we do like a 30-second epic, and that's how we stage sleep. Sleep apnea, the gold standard is continuous positive airway pressure, Cpap. There's lots of things out there. People are like, I don't want to do Cpap. There's all this horror stories. The truth is, if you connect patients with a sleep specialist, we go through the report with them and we say, you stop breathing every other minute or once a minute and your oxygen goes to the 50s. And we really kind of go through that report, but a lot of times patients may have that diagnosis of sleep apnea and they're told, oh, you have severe sleep apnea, and they're just put on Cpap with not really having that education there. And so when you connect your patients with the sleep center, we're able to really kind of go through that. Plus we have a respiratory therapist to go through and work any issues. And so there's an alarm going off outside. There's also an oral dental appliance that's approved by the Academy for people with more mild to moderate apnea. And what that does, it's not one of those that you boil and, get at, your local your store. This one's bulky, and what it does is bring your lower jaw forward a couple of millimeters to open up the back of the airway. And then, of course, if weight is an issue, we may work with our patients to, set up a consultation with nutrition. Sometimes people just have positional apnea, and there are strategies that we can use to treat, those patients that just have apnea in certain positions. Circadian sleep-wake disorder is not going to dig too deeply in here, but there are several of them. There's things like jet lag, which we've all experienced, and it's not really a major issue. But when you're on rotating shift schedules or doing night float and things like that, there are individuals that don't tolerate that as well. And, we know that people that work nights, like especially for longer periods of time, may be at more risk for other medical issues. So timing is very important. And I can't express that, when I shared my personal story, even how profound the effects were for me. And so I know that if I stay up a little later or have an irregular sleep-wake schedule, I'm not going to be at my best. And just knowing that, I think, is important. So let's transition to insomnia. So we talked about falling asleep within 5 minutes. Now, if it's taking you longer than 3 or 30 minutes, okay, so people are probably like, oh, that's me. So if that's happening more than 3 times a week for more than 3 months, guess what? You already meet the diagnostic criteria for insomnia, which is the most common sleep disorder we see in our sleep center. And so what's the big deal with insomnia? Well, it's difficult to treat. A lot of people just say, well, it's just, I always take an hour, fall asleep, or I go to sleep, no problem. Then I wake up and then I can't go back to sleep, right? And so, insomnia, we're realizing that there's a lot of risks associated with it, including cardiovascular risks, hypertension, reduced quality of life, more mood disorders, issues that come up with that, missed work, memory, concentration, headaches, a lot of things that can get tied in with insomnia. It's a clinical diagnosis. Again, I mentioned earlier, you don't do a sleep study for this. They have to have, they have to have everything in column, or they have to have some of the things in column A, and then it has to have some kind of negative consequence, right? If you say like, oh, it takes me like 2 hours to go to sleep, but it's not causing any problem, then you don't meet that criteria yet. Okay. But the truth is most people do have something going on in column B. Okay. So this is the updated diagnosis. And I know many of you are probably diagnosing yourself right now, and that's okay. I want to put this out there for you and your patients. So lots of studies showing that I like to say patients with insomnia, it's like the car that's always running or the light switch that's always on. They can function, they can get by, right? Maybe not the best that they normally would, but the minute you need to like get that car to take off and go, that's where the breakdown happens. So people with chronic insomnia have increased sympathetic activation, not just at night, but 24/7, abnormal secretion, like with hormones like cortisol, increased metabolism in the brain, and then I've done work with transcranial magnetic stimulation showing that people with chronic insomnia have increased cortical excitability. It's always like just on, there's always stuff going on. And you can see like a lot of times patients with insomnia, they're either like thinking about things or worrying about things, and they just can't like shut down so that they can go to sleep. And so they have higher EEG activation. So a lot of times we'll see like riding on their delta waves or their sleep waves, they have these faster rhythms, like rhythms that we would see when people are awake. So they have that like kind of riding on that. And so there's a lot of work going into, kind of better understanding the micro electrophysiology when it comes to sleep. So I'll stop for a question.
So thank you. Are new airing micro CPAP devices effective for sleep apnea?
Which devices?
Airing micro CPAP.
Airing?
AIRING micro CPAP.
Oh, I'm not exactly sure what device you're talking about, but there are some small like CPAP types of devices that are obviously very compact, and they're not as good, but it's probably better than nothing. There's a ton of work going into obviously trying to get better treatment strategies so that people don't have to have the CPAP device, which works really well, but obviously it's not as comfortable and it has its own issues. But I think like in the next few years, I think we're going to see better quality devices, and the devices keep getting better all the time.
What supplement or food do you recommend to help us fall asleep?
Oh, well, I would say a couple things when it comes to food. And believe me, I was there as a resident. Like, you hadn't eaten all day to go home and eat something crazy like pizza and then pass out. So don't take heavy meals. It's more about what not to do than what to eat. So no heavy meals, no spicy meals. Like I would, like if you're somebody, because then if you have GERD or untreated apnea that hasn't been diagnosed, that's going to make your GERD worse. You don't want to go to sleep hungry, because if you go to bed hungry, you're going to wake up and then you're going to trigger your insomnia. So like a light snack, maybe some fruit, yogurt, a small bowl of cereal. Are there like foods out there that have like some natural sleep process? Yeah, like tryptophan, even lettuce, warm milk, certain teas. Again, finding what works better for you, doing some little experimentation, right? Like, oh, that chamomile tea like really helped relax me. Okay, but put that in your bedtime routine. I just, even as a sleep specialist, like back, I was like, what? Who does a sleep routine? But God, it's so important. The brain is so complex in so many ways, but doing these little strategies can make a huge difference.
Don't drink caffeine.
Yeah, right. Caffeine, like doing your espresso, like right at bedtime, probably not a good idea. I'm sure many of you probably don't smoke, but be surprised how many people that do smoke are like, yeah, smoking a cigarette as their bedtime routine. I mean, that's the stimulant.
It's the last one, Dr. Salas, and then I'll let you continue. Other than improving sleep quality on PSG, does Cpap improve consequences of OSA, things like hypertension, attentional issues, cardiovascular mortality?
Definitely. So yes, right. And so that's the biggest reason we really, take time to really educate the patients. Many, like I mentioned earlier, the cardiologists, they won't do the ablation if somebody has undiagnosed, untreated sleep apnea, because they're going to kick back right into it after ablation. There's studies showing that, the stroke reoccurrence, better control of hemoglobin A1C has all been, backed with studies out there. Now, of course, if you're more severe and the type of sleep apnea you have, then obviously it's not going to be to the same extent if you're kind of more on the mild side or you have like positional apnea, but definitely out there can make a big difference on patient outcomes. So getting back to insomnia, which is very difficult to treat because it's a mixed bag, right? I could have 10 patients with insomnia. Well, everyone has different reasons why they're awake, and everybody has different medical issues going on. Everybody has a different sleep environment. So it really becomes kind of customized on how we treat them. Back in the day, like, people, and this is like taken from an article, but to treat your insomnia, you would just follow these black lines and then your eyelids would get tired. Or better yet, you could do wine with cocaine. That could treat your insomnia. So, lots of things. It's been a problem for a long time. What we're doing in our sleep center is we're using, again, you don't need a sleep study for insomnia, but we are now doing this ambulatory sleep device in our center clinically. And it helps us kind of see more objectively, like what the patient's sleep looks like. So they take this home, they'll use it for 1 or 2 days. We stage their sleep, we look at arousals and different markers. And what we may do, or what we do is like, we do a pre, and then after they undergo therapy, which I'll talk about in a second, we'll compare. And sometimes patients will say, I think I'm better, but I just was hoping that I, was having better sleep. And then we can say, well, actually, you're actually taking less time to fall asleep. You're actually staying in delta sleep a little longer. You're not having as many transitions or as many arousals. So it's been very helpful for us in our practice to use this device. So we are, kind of moving up in things. Cognitive behavioral therapy is the gold standard to treat insomnia. And so that's why we have a sleep behavioral psychologist as part of our team, and they work to really kind of understand what are the specific issues for that particular patient. They come up with an individualized plan, and that's what's been proven to work the best. Sleeping pills, I always say they're like Band-Aids. They may help, but just like a Band-Aid falls off, it's not usually long-term. Every now and then you'll have somebody that really can benefit, but for the most part, we don't. And most of the time when patients come to me on medications, I'm trying to take them off. I'm very frank about, like, that's my goal, is to get them off of these medications. Many of them haven't even been tried on cognitive behavioral therapy, which again is our gold standard. So I'll get them started on different things. And for those of you that read the Continuum, we just had a recent sleep neurology book that came out, and I was one of the co-authors on the Insomnia chapter. And I'm putting like other things that, like, I'm like, hey, whatever works, right? So like, for those of you who are familiar with ASMR, and you can see the definition there, but people are like really kind of customizing these bedtime routines to really kind of optimize their sleep. I have this included. This is the stimulus controlled therapy, which I like to start patients on. It's a validated therapy. I've made some modifications on my own, and I have this in the Continuum chapter for you to use. And so this is kind of retraining your brain, because it becomes conditioned when you have insomnia. And even though you're like, oh, I'm not gonna get good sleep, I'm gonna have a big test tomorrow or presentation, and you just kind of, your brain kind of learns that pattern. It's like, okay, we're going to go to bed. It's going to take 2 hours to fall asleep. And then we're going to have some light sleep. Then we're going to wake up a couple more times. And then we're going to start worrying about like being tired the next day. And then you just keep doing that. And you don't just one day like kick out of that. It continues. So these are some other approaches that we'll use in cognitive behavioral therapy, just to give you some examples. It's really a more comprehensive approach, and it's really dependent on who the patient is and what their issues are. Some of you may be aware that I've gotten really into coaching, and I actually use coaching with my patients. I'm certified in strengths coaching, and so when my patients come in, I try to find out what their strengths are and use that strengths-based psychology to really connect with them, especially my insomnia patients, because using a strengths-based approach shows that people have a better quality of life, they're more energetic, they're more rested, and they'll have decreased things here on the right, sadness, and burnout and things like that. I've even connected with coaches, like, life coaches and things like that, because I know that elephant in the room has always been like, well, what are your life goals? What are your choices? All of those things can impact sleep. So now I'm like even referring some of my patients not to really like work on their sleep, but to work on other aspects of their life that I know are having an impact on their sleep. And hopefully I can get a paper out on that pretty soon. But it's been very helpful. And again, so I use the coaching in my way to better connect with my patient. And that's a whole nother talk on Parasomnias, which I can get into, and having that better connection with your patients. But coaching has really been another element that I think is very useful with patients. This was a study that came out really looking at different traits that patients have, and depending on what kind of traits they have, they do better with certain therapies. So we're really kind of digging into this now and learning, like, okay, if this patient, for instance, has PTSD or has this personality trait, they're going to probably do better with this therapy versus this one. So again, precision medicine, really trying to use evidence-based medicine, and kind of tailor to the person in front of us, right? That, is an individual, really kind of seeing them at their level, seeing what their beliefs and their experiences in the past, and really coming up with a customized approach to deal with whatever sleep issue they're having. All right, so let's talk about restless leg syndrome. Another clinical diagnosis, there's not a test for it. And if there's anything I want you to leave here with today, is that when you see periodic limb movements on a sleep study, like, because we'll say this patient has increased periodic limb, that does not mean they have restless leg syndrome. That, like, get that out, okay? If they have periodic limb movements, that means you should ask them about symptoms of RLS. And here are the criteria. And I'll show you a better slide in a second. But they have to have all these. If they have 2 of these, that's not RLS. They have to have all of it. What makes it a sleep disorder is it has that circadian component. So the symptoms only come out at bedtime or at nighttime, or they're worse because the disease progressed. Our colleagues, the movement neurologists, also see restless leg syndrome because obviously it's a movement disorder as well. Mimics are very common. So we put a lot of stress on making sure it's not a mimic. And here's the international classification sleep disorders that we use. And so again, just like insomnia, you can have the column A and B, right? But if it's not causing a problem for the patient, then you're not going to treat it. right? Because it's not having a problem, right? Now, if your patient comes in and they're there with their spouse or their partner, and they're saying like, I don't have a problem with it. Like, yeah, sure, I meet some of this criteria, but I don't have a problem. It's really this person's problem. You don't want to treat the patient to treat the person in the bed with them. And I know that seems obvious, but it does happen more often than I would like to admit. So these are some of the other disorders or behaviors that could be associated with restless leg syndrome. Especially neuropathy, certain medications, like some of the dopamine antagonists can make RLS worse. So you definitely want to look into those. Again, substances, things like that can make RLS. So if you ever have a patient that's admitted and they're given like Reglan or Compazine, and they start having worse RLS, like always look at the medication. So a lot of the SSRIs and TCAs can definitely exacerbate RLS. And so it's really just taking those medications off, and we can make recommendations for that to optimize that, because sometimes patients do need to be on SSRI. Behaviors, we're really big into that. There's some studies with yoga, acupuncture, again, really finding what works for the patient. I like to use weighted blankets for my patients. I like to use it so much that I even have a demo weighted blanket in my office. So I'll just go drape it on the patient. And so they could feel like, look, when you're watching TV, like have that, it's not going to take away the RLS, but it can help. We often will I'll send my patients to the sleep behavioral psychologist to really kind of optimize their sleep behaviors. I found that that's really helpful for patients. And then, sometimes like warm bath, like all of these other things, again, precision medicine, finding out what works, encouraging the patients to be experimental, but not too experimental. And here's a table of things that patients have done because they've learned about it in on the internet, right? On online. Some of them are pretty benign, like drink water, peppermint tea, but dead arming yourself, which is basically taking a bat and hitting your legs as hard as you can until they go numb, probably not so good. Or drinking pickle juice when you have end-stage renal disease, right? So some of these, so always ask what your patients are doing, because I guarantee you they're getting online and doing some not so good stuff. And they won't tell you this, but if you ask them, you'll be like, oh, do you ever get online and like, try other things? And then that's when this stuff comes out, and hence my table here. So no, you gotta put them in check and say like, you can't be doing this. There's some problems with that. So here's some of the medications that we use to treat RLS. And I know some of you are like pretty surprised about opioids. Is it first line? No, it's not first line. It's not even second or third line. It's way later. And the truth is RLS is a different beast from chronic pain. And we don't really see, I've never had a patient, never had a patient that, had substance misuse with that, because we use such small doses. And again, it's a different mechanism that's involved here. And don't use that as first line. Usually now in our practice, we see people from all over the world that have pretty complex restless leg syndrome. So by the time they get to us, they've tried everything. And so we may kind of try things in the past, but opioids may be something that we'll consider. But I gotta say it's tough now because of the stigma. A lot of other colleagues that aren't trained in this area really, just aren't aware, and they think that we're just throwing opioids to everyone. So it's a big problem. Sleep medicine, we're trying to, address this, but, definitely want to look for iron status. Dopaminergics are really the common ones, and anti-epileptic medications can be very helpful. The Green Journal comes out with practice guidelines. And so this one's kind of a little outdated, and I think it's from 2016. But then, the AAN also has these like one-sheeters that you can put on your, on your workspace. They're very good to kind of reference. I'm not going to get too much into augmentation, but essentially augmentation happens when you prescribe a dopamine agonist to a patient. And over time, what happens is the body or the brain stops releasing like the natural dopamine. And so the RLS kind of comes back. And so the physician will say, okay, let's increase the dopamine agonist. The symptoms get better, but this kind of keeps going. And it's not because the disease is progressing. It's because of the changes that are happening because of the medication. And when you have to withdraw these patients, which a lot of times we do later on, their withdrawal can be pretty severe. Remember, you all know dopamine is a reward neurotransmitter, and taking somebody off who's been on high doses, especially over long periods of time, who is augmented, can be very, very, very severe, very severe. And then you have to worry about impulse control disorders and behaviors, not to the extent that we see in patients with Parkinson's who are higher doses of the dopamine agonist, but these do arise. And this is one case report that we wrote up regarding this 86-year-old woman who was placed on Sinemet, which is a big no-no for RLS, by the way. There's a caveat to that, which I'm not going to discuss here, but it's pretty much not, recommended. And what she started hoarding Sinemet. She would get it from different doctors and then started taking it on her own after she had built a stash of it, and started having very severe dyskinesias. So that was her compulsive behavior. And we've had others, like I've had others that, the gambling, again, not to the big extent, but, I've had some other very interesting presentations of some of those compulsive disorders. So I know that's been a whirlwind, but I'm going to kind of end here with some strategies to, kind of improve. And you can look at some of these things, hopefully to implement, but there's a lot of things that we're all doing that are not helping us. And you're already, busy physicians, we got a lot on our plate. And so all of these little bad habits that we all have are just making it worse. And I'll go to the next slide, but I see there's a question.
Second. Okay, so first of all, thanks so much. I'm not a sleep doctor, but I'm a neurodegenerative doctor, and sleep is always an issue with our patients. So let me just find the questions. Okay, so going on the question of food and natural supplements to go to sleep, for people who use melatonin, what dose do you recommend? And what is the risk of using too much impacting ability to sleep without it?
Yeah, so that's a good question. So we use melatonin to help with our patients in clinic with circadian rhythm disorders and/or insomnia. It just depends. And what I do, and I have this embedded in my stimulus control instructions that I showed you that are in the continuum. I use typically anywhere from 0.5 up to 3 milligrams of melatonin. It depends on the brand. Now, obviously it's not FDA controlled, but there is like at least one study that showed one particular brand that had some better data. So sometimes I'll, like, if a patient does ask like for a particular brand name, I might suggest that, and I have no stock in that particular brand. In the back several years ago, we used to use higher doses, like 9 milligrams or even 12. But now many of us have gone back down, and it's like 1-3 milligrams, and you want to get it 2 hours before the bedtime, right? So if you're going to shoot for 11 to 7 for your patient or for yourself, or if you're going to shoot for 1 a.m. to 6 where you're still sleep deprived, but at least you're more consistent, you can take the melatonin 2 hours before bedtime. And the other strategies to use is not just melatonin, but don't have all your lights on. Put dimmers in your smartphone and your laptop so you're not getting that alert, because we know from studies, genetics play a role, and some people are more sensitive to their schedule being off, to light, and so all of these kind of factor in. So we do use melatonin quite often. I would say that it's possible that you could build that tolerance, or you can build that dependency, like where I need my melatonin because it becomes part of your bedtime routine. But honestly, I don't see that as often as I do with the prescribed hypnotics.
How the neurotransmitters are balanced, dysregulated between deep sleep, high alert sleep, and non-24-hour and coma. And then the second question is, which molecule drives to fall rapid asleep when the body is physically tired?
Yeah, so that I think we're still figuring it out. There's all, there's the on and off switch, histamine, they're all playing roles in there, and we're barely getting into better understanding that. So it's a good question, and I think a good research question. So if you're interested, please reach out. Maybe we can get you to apply to sleep. Yep.
Do you find wrist actigraphy in smartwatches such as Apple and Garmin's to be helpful in your practice? Some of these allege they can describe REM, light, deep sleep lengths and times.
Yeah, so, no, they can't, at least not yet. Are we going there? Probably, but these are not medical devices. Do I use them in my practice? Yes. So if patients come in and show me like their Apple Watch data or their, whatever Fitbit, I will point out things like, oh, look how inconsistent your sleep wake schedule is, like you're going to bed at different bedtimes, or, you're having like big nap times during the day. These devices are not equipped. Again, they're not medical devices. So this whole business of REM and this and that, it's just not there yet. I think we're going to get there, but we're not there yet. So I tend to use them more as like just, like helpful information. But would I base anything like a medical recommendation based on their data that they're coming in with, not a medical device? No, we're just not there yet.
Okay, thank you. Does midday nap help to sleep less at night?
Yeah, so naps, a strategic nap can be very helpful. And so when I recommend naps, especially for house staff, it's like you want to do it before 3 p.m. And that's because after 3 p.m., it really can interfere with your homeostatic drive that I mentioned earlier. Ideally, 10 to 20 minute nap, because that's a nap. Again, 3 hours, even 1 hour, that's not a nap. You're starting to get into homeostatic drive. And then what'll happen is you'll transition to the deeper stages of sleep, and you're going to have sleep inertia. You're going to be groggy, and it's just not good.
Yes, definitely. If he says people need 7 to 8 hours of sleep, is 7 hours equivalent to 8? And would 9 hours be better? Is there such a thing as oversleeping?
Okay, so again, it depends on the person, right? You may be a 7 hour person. You may be a 7 hour, 20-minute person. Somebody else may be a long sleeper. There are long sleepers out there that they need 10, 11 hours of sleep. And if they don't get that, they're sleep deprived. I mean, they're out there. There are short sleepers. Again, many people think they're short sleepers, and they're really not. They just are good at compensating. We end up seeing those patients later in life when they come see us in clinic and say, you know what, I used to always sleep on 5 hours of sleep, and now I just can't even do it. It's like, well, now you have like all these other medical issues, and now you're just not able to compensate. So it just depends on the individual. We're all unique human beings. And, I think for the most part, we fall in that 7 to 9, but you got to experiment, test it out. Like I said, do what I did at first, 11 to 7, if you can. Like, obviously, if you're on a rotation that you can't do that. But if you're on elective or you're on vacation, experiment. You'll be surprised on what things can be very helpful, even down to the pillow, a good mattress, like changing your sheets once a week, right?
Is there such a thing as catch-up sleep? For example, if a person sleeps 4 hours one night, can they compensate by sleeping 12 hours the next night?
So there is a little bit of catch-up, but the truth is, like, if you're chronically sleep deprived and chronically have a variable sleep-wake schedule, catching up with a 5-hour nap on the weekend, maybe it's going to help pay back a little bit of your sleep deprivation, but it's never going to counteract the chronic, consequences of that poor sleep. So I would say, like, in terms of an acute, like if you did a crazy, like, you had a busy call schedule like that one day, yeah, you definitely want to go and probably make up that sleep, because that's going to help with some of that acute, right? But like, you can't be like, okay, I'm for 5 years, I'm going to have just crazy sleep, and then, I'm going to make it all up. Like that just is not the case.
Yeah. Do you think long-term melatonin use can cause cancer or hormonal imbalances?
I don't know. I know from from animal studies, like, there's been some research about increasing high blood pressure, maybe infertility in animal studies. I don't know about this. I mean, it certainly has not reached the attention for us to be like more. And honestly, we don't really, when we use melatonin in our center, we use it for specific times, right? Because the whole goal is to get people back on a schedule, back on a routine, having good behaviors, and going from there.
Okay, so last question, or rather last but one, how is genomics changing the field of sleep neurology?
So I would say it is. And it's, again, with this whole precision medicine, really finding out like who the individual is in front. So getting their biological information evidence-based medicine, that person's unique experience, their beliefs, their resources, their support system, and really factoring it into precision medicine. And there is a lot of work going into genomics in terms of, like, we know, for instance, some people with sleep apnea, they could have severe sleep apnea. We treat it with Cpap, but they're still tired. And so there are effects in the white matter of these patients. And you're having like certain phenotypes that respond well than in other zones. So we're just getting into all of this. So it's definitely a good, an area of interest. And I think we're gonna, see our field really kind of take leaps ahead. We know that certain individuals respond better to even like flu, vaccines and things like that, and there's a lot of work being done. So I'd say more to come on that.
Yeah. I think we're just at 12. If it's okay with you, I can ask you one more question, Dr. Salas.
Sure.
Should program directors encourage residents to take strategic naps in call rooms during the workday as needed? As a trainee, it is intimidating to request time to sleep at work, but when you are at work so much, it may be the only strategy to improve wakefulness while at work.
Yeah, I for the most part am supportive of that. I've even worked with our residency program at times, like, even like working with light box therapy and the caffeine nap, taking like the idea that you take a caffeinated beverage and then go down for a sleep like for 20 minutes, and then you wake up and by that time the caffeine's kind of kicking in. So there are some like strategies that I think could be helpful. And I think certain programs are trying to do that because, obviously it impacts like wellness, right? So I think we're seeing more people, like more programs investing in sleep as a part of, fatigue mitigation and improving well-being. So I'm supportive of it. And, I think we're going to see a lot more, people in programs, trying to do such things.
And thank you so much. That was excellent. And thanks for answering all the questions, Dr. Salas. Have a good day.
Yeah, thanks.
Yes. Thank you, everyone, for joining the 5th FAAN Virtual Resident Education Lecture Series. A special thanks to Dr. Salas and Dr. Chitnis for joining us today. These are recorded and will be available through AAN.com, so keep checking the link that I put in the chat, otherwise AAN social media channels. So thank you for joining us, everyone, and have a great rest of your day.